efficacy and safety of direct oral anticoagulation for venous thromboembolism, prophylaxis in high-risk burn patient, randomized controlled trial. I don't have any conflict. Venous thromboembolism in burn patient presents unique challenges in terms of pathophysiology and management. However, the efficacy and safety of VTE prophylaxis in thermally injured patients continue to be elusive, as it has never been studied in prospective RCT. The true incidence of DVT in high-risk burn patient is actually and mainly actually variable, mainly because it depends on the screening, instability, prophylaxis use, and the potential risk profile of the patients. This is the dilemma, how to balance between prophylaxis and bleeding. You know, the burn patient has a high intensity for bleeding, and you are going to give medical treatment or anticoagulation. How to make this balance? Let us think about it. This is the approved DOACs in burn, dabigatran, rivaroxaban, apixaban, endoxaban, and recently rivaroxaban ODT. Why ODT? Let us discuss. As you all know, the problem in DOACs is it has already compared in bleeding to warfarin. This is the dilemma, and the bleeding does not analyze probably. The GIT bleeding does not consider the upper GIT and lower GIT. It is totally GIT bleeding. This is another dilemma. If you see the upper GIT bleeding will be about 1.7. If you add it to the lower GIT bleeding, it will go for 3.2. Treble score for the upper GIT. Why lower GIT bleeding is very important and how it occurs. Let's think about it. GIT is the only system of the body that both under systemic and topical anticoagulation effect, especially with hidden lower GIT lesions. What does that mean? The effect of anticoagulation in the lower GIT depends on the systemic absorbed drug and the time of contact between the drug and the intestine. This local effect is mainly 4 times greater than the systemic effect. So we have a chance to lower this topical effect of anticoagulation. How we can diminish this topical effect? Very simple. Make the drug suitable. Then it will be totally absorbed in the duodenum. This is the idea. If we can make the wax soluble to be totally absorbed in the duodenum, it will not pass to the lower GIT, and it will has no effect, topical effect on the GIT, and then we don't have any topical effect of the GIT bleeding. This is the idea of losing this effect. This is the important point. We have to get rid of this topical contact. That's why we think to use this newly drug in our study. As you see, this is if we decrease or lose this local effect, the lower GIT bleeding will be 0. It was 1.7, it will drop to 0. So the objective of our study is to evaluate whether DOACs reduce the incidence of VIT compared with standard prophylaxis in high-risk patients. Secondary endpoint, access safety, measure bleeding relevant to non-bleeding, evaluate biomarker changes, access, IC hospital outcome. And this is our study population. It is composed of adult patients admitted of acute thermal burn injuries, screened for eligibility within the first 48 and 72 hours, Inclusion criteria are above 80, surface, total surface, permanent surface area, more than 30%. Expected immobilization, of course, with signed informed consent. The exclusion, the active bleeding, platelet count below 50, and creatine clearance below 30 millimeter per minute, hepatic failure, contraindication into anticoagulation, and the current therapeutic anticoagulation. This is our study design. It is prospective, multicentric feasibility and safety cohort parallel group, randomized 1-to-1, and open label with blinded outcome assessment. Study concluded tertiary burn patient, including patient admitted to the ICU burn unit and ward unit. The study placed expected to run over 1 year. Ethical approval obtained from local institution review board, and written informed consent will be obtained from all participants or their legal representative prior to the enrollment. Patients, one group will take DOACs, rivaroxaban DOT, 10 milligram, compared to the control group, low molecular weight heparin. The primary endpoint, complete VTE endpoint, symptomatic DVT, asymptomatic DVT detected by DOACs or Prophylactis confirmed by imaging, screen plan, duplex ultrasound on the first and second weeks, and earlier if clinical manifestation appears. Safety endpoint, primary safety, measure bleeding, second safety, clinically non-measure bleeding or any bleeding. Sample size, this is the steps how we measured our sample size, and it came to 400, 200 patients in each group. To conclude, Mr. Chairman, it's an open invitation. Please, I ask you to join us in this multi-center study and see the effect of the newly rivaroxaban DOT drug and see the efficacy and safety for its use in prophylaxis in burn. Thank you.